Hello, my name is Ji-Eun Lee. Today, we will discuss a case involving the earliest findings of septic arthritis. We have a 28-year-old woman who recently experienced an inflamed toe and severe knee pain 2 days ago. Let's examine two key findings of septic arthritis as observed in this case. Firstly, we see periarticular soft tissue edema. In this patient, there is significant periarticular soft tissue edema in the posterior aspect of the knee, along with a large amount of joint effusion. Secondly, there is mild increased T1 signal of the synovial lining and enhancement. The MRI shows a thickened synovium that has a slightly higher signal than the knee effusion on T1 weighted imaging. Additionally, there is a noticeable enhancement of the thickened synovium. In the context of non-contrast MR imaging, it is important to note that joint effusion and perisynovial edema are commonly seen in septic arthritis cases. Unlike other causes of joint effusion, infection leads to marked inflammation and edematous changes in the surrounding soft tissues, including fasciitis and myositis. Furthermore, post-contrast imaging plays a critical role in evaluating the degree of synovial inflammation and detecting the presence of perisynovial abscesses. This increases our confidence in diagnosing septic arthritis. It's essential to include T1 weighted sequences in the imaging protocol to evaluate for concomitant osteomyelitis, which can coexist with septic arthritis. Thank you for watching. If you found this video helpful, please remember to like it. Hello, my name is Ji-Eun Lee. Today, we'll delve into the bone erosions in pyogenic arthritis, focusing on MRI findings. We'll examine a case of Staphylococcus aureus septic arthritis to illustrate the progression of this condition. Let's begin with our case presentation. The initial MRI showed no signal change in the bone marrow. This is often the case in the early stages of infection. 6 days after the synovectomy, we observed bone marrow edema-like signal intensity. T1 weighted images showed low signals within the subchondral bone, and fat-suppressed proton density weighted imaging displayed a thin rim of subchondral edema and pericapsular edema. 21 days after the synovectomy, the MRI clearly demonstrated irregular erosion. We saw an intermediate T1 signal and an increased fat-suppressed proton density signal associated with cartilage loss. These findings indicate progressing synovial inflammation, destroying cartilage, and marginal erosions. As both cartilage and cortical bone are destroyed, joint space narrowing occurs. It's crucial to note that MRI is highly sensitive and specific for detecting early cartilaginous damage and characterizing joint effusion. This makes it an invaluable tool for early diagnosis and monitoring in septic arthritis. Thank you for watching. If you found this video helpful, please remember to like it. Hello, my name is Ji-Eun Lee. Today's topic is the usefulness and considerations of using MRI to monitor the therapeutic effects of septic arthritis. Let's start with the MRI performed 6 days post-synovectomy. In this image, we can observe several key findings. Periarticular soft tissue edema. Heterogeneous joint effusion containing debris. Bone marrow edema-like signal intensity. Now, let's move on to the MRI performed 21 days after the synovectomy. The question we need to consider is, does this imaging suggest the patient is being successfully treated? If not, what findings lead us to that conclusion? In this MRI, we observe the following. Increased lamellated hyperintense synovitis. Increased size and extent of bone marrow edema-like signal intensity. Based on these observations, it does not appear that the patient is being successfully treated. The increased synovial inflammation and worsening bone marrow edema indicate ongoing infection or inflammation. To summarize, let's discuss some critical points regarding the monitoring of therapy for septic arthritis. Joint effusions and abscesses. The size of these fluid collections is crucial for monitoring therapy effectiveness. A significant decrease in these sizes is typically associated with successful treatment. Persistent findings: synovial thickening and enhancement, periarticular myositis/cellulitis. Hello, my name is Ji-Eun Lee. Today, we will delve into the characteristic findings of rheumatoid arthritis, focusing on erosion and synovitis as seen through MRI. Firstly, let's discuss the bone marrow edema-like signal intensity. This is often seen in the presence of synovitis, and it appears as a hyperintense signal on T2 weighted images. Additionally, we encounter intermediate signal intensity PANUs, which is crucial for identifying early synovial proliferation. This PANUs can invade and erode adjacent cartilage and bone, contributing to joint damage. Next, we have marginal erosions. These are erosions at the margins of the joint, typically adjacent to the meniscal recesses. These erosions are indicative of progressive joint damage in rheumatoid arthritis. Now, let's focus on synovitis. In MRI, synovitis shows up as a low T2 signal intensity area, which is less intense than fluid. This is due to the uneven and thick synovial proliferation. It's essential to recognize these signals as they help differentiate between simple fluid and more complex synovial pathology. In early, active RA, we typically see hypervascular PANUs, which shows high T2 signal and can be mistaken for joint fluid. On the other hand, in long-standing RA, especially in burnt-out cases, fibrous PANUs tends to predominate. This is easier to distinguish from joint fluid due to its lower T2 signal. Thank you for watching. If you found this video helpful, please remember to like. Hello, my name is Ji-Eun Lee. Today, let's explore rheumatoid arthritis, and rice bodies. In our imaging studies, we observe numerous tiny nodules with intermediate signal intensity. These small, irregular intra-articular structures, known as rice bodies, demonstrate intermediate signals on both STIR and T1 weighted images. It's important to note that these tiny bodies show no fat signal, as they are composed of fibrinous tissue. When we examine the sagittal image, we can see a dependent layering pattern. This characteristic indicates that these particles are mobile rather than fixed to the synovium. While rice bodies are indeed a feature commonly associated with rheumatoid arthritis, it's crucial to understand that they are not exclusive to rheumatoid arthritis. We also encounter these structures in other conditions such as tuberculous arthritis, various infectious arthritis, juvenile idiopathic arthritis, and chronic synovitis. Thank you for watching. If you found this video helpful, please remember to like it. Hello, my name is Ji-Eun Lee. Today, we will discuss 3 cases of gout displaying intracapsular locations of Tophi. In the first case, the tophus is located within the posterior cruciate ligament. MRI shows an intermediate to high signal intensity cyst adjacent to the PCL. Arthroscopic examination reveals the cyst contents to be a white, chalky paste-like tissue. The second case involves a tophus located in the popliteal groove. The MRI features an intermediate signal intensity tophus involving the popliteus tendon, accompanied by erosion of the popliteal groove. In the third case, the tophus is situated in the intercondylar notch and joint recess. T2 weighted MRI reveals heterogeneous intermediate to high signal intensity tophi at the lateral aspect of the suprapatellar pouch and the intercondylar notch. Intracapsular locations of tophi include various regions such as the medial infrapatellar fat pad, anterior joint recess, popliteal groove, and intercondylar notch. These cases illustrate the variable MRI features of gout, which range from intermediate to high signal intensities on different weighted images. Tophi can manifest as intermediate or low signal intensities on T1 weighted images and heterogeneous signal intensities on T2 weighted or fluid-sensitive sequences, often due to varying calcium content. Thank you for watching. If you found this video helpful, please remember to like it. Hello, I am Ji-Eun Lee. Extracapsular tophi typically affect the prepatellar bursae and extensor mechanism. Let's examine a case. Let's first look at a normal quadriceps tendon. The quadriceps tendon exhibits a layered configuration, creating a laminated appearance. This is best appreciated on sagittal MR images as low signal intensity tendinous bands separated by linear interdigitating fat. Now, let's compare this with a case of intratendinous Tophi deposition within the quadriceps tendon. Although T2 weighted images do not clearly distinguish these features, contrast-enhanced imaging reveals thickened, heterogeneous Tophi. Additionally, there is extensive enhancement of Tophi within the quadriceps tendon and evidence of patellar erosion. Intraosseous Tophi within the patellar erosion are also enhanced on the contrast images. Radiographs show focal osteolysis with sclerotic margins of the patella, indicating the presence of an intraosseous tophus. Let's consider another gout patient. In this case, a linear, hyperintense signal is observed within the patellar tendon, indicating a partial patellar tendon tear. There is also Tophi deposition subjacent to the thickened, heterogeneous continuation of the quadriceps tendon. Thank you for watching. If you found this video helpful, please remember to like it. Hello, I am Ji-Eun Lee. Let's discuss two cases. Do you think both of these cases are septic arthritis? Let's examine them one by one. The first case is acute gouty arthritis. The imaging shows a nonspecific diffuse linear synovial thickening pattern and soft tissue edema without subchondral bone erosion or bone marrow edema. During arthroscopy, Tophi deposition was found throughout the cartilage, capsule, synovium, ligaments, and meniscus. The second case is septic arthritis. The imaging reveals bone marrow edema-like signal intensity and bone erosion, along with lamellated synovial thickening. While not observed in this case, soft tissue abscess formation was only seen in septic arthritis. Therefore, evaluating the presence of an abscess is crucial for differentiating between these two conditions. In summary, while septic arthritis and acute gouty arthritis can both present with painful, swollen joints, their imaging findings can help differentiate them. Acute gouty arthritis often shows nonspecific synovial thickening and soft tissue edema without subchondral bone erosion or bone marrow edema. In contrast, septic arthritis commonly presents with bone marrow edema, bone erosion, and lamellated synovial thickening. Thank you for watching. If you found this video helpful, please remember to like it. Hello, I am Ji-Eun Lee. Today, I will discuss calcium pyrophosphate dihydrate deposition disease, commonly known as CPPD. This condition is a crystal deposition disorder that primarily affects middle-aged and elderly individuals. It is responsible for various conditions such as chondrocalcinosis, pseudogout with intermittent inflammation, and pyrophosphate arthropathy, a type of non-erosive arthritis that mimics advanced osteoarthritis. One of the key characteristics of CPPD is its tendency to affect joints symmetrically. It preferentially involves the patellofemoral joint more than the femorotibial compartments. One of the hallmark features of CPPD in the knee is well-marginated smooth scalloping of the anterior femoral cortex at the level of the extended patella. Radiographically, CPPD can often be identified by the presence of chondrocalcinosis, particularly involving both menisci. Additionally, in this patient, calcifications can be seen not only in the meniscus but also in the gastrocnemius and popliteus tendons, hyaline cartilage, crucial ligaments, and synovium. Thank you for watching. If you found this video helpful, please remember to like it. Hello, I am Ji-Eun Lee. Today, we will examine a case of localized type Tenosynovial giant cell tumor and discuss the MRI findings. Afterward, we will briefly review the key points of this condition. First, there is a blooming artifact. This artifact is due to hemosiderin deposition, which causes low to intermediate signal intensity across all sequences, especially noticeable on gradient echo sequences. Second, there is an absence of calcification. There is no calcification within the tumor. On T2 weighted images, the tumor displays variable signal intensity. It appears as a well-circumscribed, non-mineralized mass located in the anterior intercondylar notch. Third, it is often seen as a pedunculated nodule. We can observe a pedunculated nodule. This nodule shows a slightly hyperintense signal on T1 weighted images relative to skeletal muscle. It is connected to the adjacent synovium by a pedicle. Tenosynovial giant cell tumor is a benign synovial proliferative disorder characterized by villous and nodular projections. It can be either localized or diffuse and is usually monoarticular. There are two main forms. Localized form, previously known as focal nodular synovitis, this form is generally small and ovoid. Diffuse form, previously called pigmented villonodular synovitis, it involves a more extensive area of the synovium but shares similar histological features with the localized form. Tenosynovial giant cell tumor is marked by recurrent bleeding, leading to hemosiderin deposition, resulting in a characteristic low signal intensity on all MRI sequences. Thank you for watching. Hello, I am Ji-Eun Lee. Our patient is a 14-year-old boy who came in with a palpable mass and knee pain. Imaging revealed a markedly T2 hyperintense lobulated mass with linear hypointense intralesional septation in the subcutaneous layer, extending into Hoffa's fat pad. This raises the question, could this be a simple cyst? Upon surgical exploration, the mass was identified as a synovial low-flow vascular malformation, previously known as synovial hemangioma. If there had been the presence of phleboliths within the vascular spaces, the diagnosis would have been more straightforward. Additionally, contrast-enhanced images often show avid, homogeneous enhancement, which helps differentiate these malformations from cystic synovial hyperplasia. Overview of synovial low-flow vascular malformation. Synovial low-flow vascular malformation is a benign vascular malformation that typically occurs in the knee of children and young adults. This condition often presents with pain and spontaneous hemarthrosis. Radiographs of synovial low-flow vascular malformations may reveal calcified phleboliths. These calcified structures within the mass appear as intralesional T1 and T2 hypointensities and can be confirmed via radiography. On T2, weighted fat-suppressed images, the lesion is hyperintense with signal voids corresponding to abnormal vessels. Additional MRI features may include fibrofatty septa and muscular or fatty invasion without a significant mass effect. Thank you for watching. If you found this video helpful, please remember to like it. Hello, I am Ji-Eun Lee. Previously, we observed numerous tiny nodules with intermediate signal intensity in a patient with rheumatoid arthritis. These small, irregular intra-articular structures, known as rice bodies, demonstrate intermediate signals on both fat-suppressed PD and T1 weighted images. It's important to note that these tiny bodies show no fat signal, as they are composed of fibrinous tissue. When examining the sagittal image, we can see a dependent layering pattern, indicating that these particles are mobile rather than fixed to the synovium. Let's now move on to today's case. In this instance, we observe frond-like synovial nodules within joint effusion. Notably, these nodules show high signal intensity on T1 weighted images and low signal on fat-suppressed PD images. This pattern suggests a fat-containing villonodular synovial proliferation. To differentiate, unlike rice bodies which do not exhibit fat signals, this is indicative of Lipoma Arborescens. Lipoma Arborescens is a non-neoplastic villous synovial proliferation characterized by the replacement of subsynovial connective tissue with mature fat and scattered inflammatory cells. Forms of Lipoma Arborescens. There are two forms of Lipoma Arborescens. Primary idiopathic form affects younger patients without any underlying joint pathology. Secondary form is more common and typically occurs in older populations, often superimposed on underlying arthropathies such as osteoarthrosis or rheumatoid arthritis, with a male predominance. Thank you for watching. If you found this video helpful, please remember to like it. Hello, I am Ji-Eun Lee. Let's start with the first case. This patient had an MRI taken shortly after surgery. The findings indicate the presence of intra-articular gas. Because it is gas, it appears as a signal void on various sequences, showing dark signal intensity. Additionally, the susceptibility effects of air bubbles result in the appearance of focal rounded hypointense areas with adjacent thin hyperintense rims. Now, let's look at another image. In the non-dependent portion, we see numerous round to oval shapes lesions. You might wonder, is this also intra-articular gas? To determine this, let's examine the signal intensity. Unlike intra-articular gas, these areas show high signal intensity on T1 weighted images. Additionally, they saturate on fat-suppressed sequences, appearing as low signal intensity on fat-suppressed proton density images. Therefore, these are fat droplets floating in the joint space, indicating lipohemarthrosis. Another notable finding in lipohemarthrosis is the characteristic three-layered appearance with varied signal intensities. You can observe three distinct layers: fat at the top, serum or synovial fluid in the middle, and red blood cells at the bottom. Thank you for watching. If you found this video helpful, please remember to like it.